Evan and Eva will deliver the call today. I'm just going to give a very quick update on where we are on the next slide, Evan. So we are in week 4 of Phenotype February. That means it's our last week, and I have no idea what to do in the rest of my life, but we're going to push for the end of this week working on pulmonary arterial hypertension, or PAH. This is very exciting because we had an amazing group of volunteers and collaborators who all contributed to our learning from the literature from PAH. We completed all the literature review extraction, and Evan going to give a lesson what we learned so far from those. And we, in the next 2 days, I'm going to post a list of cohorts that we need to replicate. And just like what happened in major depression, I'm hoping for another amazing group of volunteers to go ahead and replicate things in Atlas. And I'm going to turn it away right to Evan to talk to us through pulmonary hypertension and what we have done so far. Evan?
Great, thanks, Aza. For those of you who don't know me, I'm Evan Minty. I'm a general internist working out of the Foothills Hospital in Calgary, and I do some Odyssey work with Stanford Biomedical Informatics. My goal here is to actually yield the floor as quickly as I can to some other experts we have in the room. So we have Eva-Maria Didden, who's going to be presenting some work looking at cohort definitions in pulmonary arterial hypertension. We also have joining us Dr. Rohan Zomanian, who's a professor at Stanford and director of the Adult Pulmonary Hypertension Service, who collaborated with Eva on that work. And then Dr. Jason Weatherald, who is a colleague of mine and associate professor at the University of Alberta, where he specializes in pulmonary hypertension and lung transplant. And so I want to make sure we yield as much time to those experts as possible. I thought in reviewing the literature review, and first thanks to Bolu, Thamir, Septi, Andreas, Mingchung, Milu, and Judy for doing all the work and abstracting the literature in this area, that I would try to contextualize it quickly by just there's at least some of the issues that they saw in terms of observational data definitions of pulmonary arterial hypertension by some of the clinical challenges in pulmonary arterial hypertension. And so really quickly, pulmonary arterial hypertension is a subset of pulmonary hypertension. And if you look at this figure on the right, to a first order approximation, that box in the middle of that figure is your heart. The pressures in each chamber are given by the rule of 5s, which is the mnemonic that we use to try to remember those things and also illustrate all the wonderful things you can do with the number 5. The pressure coming out of the right ventricle here is about 25 millimeters of mercury at peak systole. It sits at a mean of about 15, but normal range being from 8 to 20. And when you get to above 20, you're in a state of pulmonary hypertension. You can get that way by either increasing the resistance before this pulmonary capillary network, increasing the resistance after the pulmonary capillary network, or in a process that does both. That's relevant not only as a physiology lesson, but actually if you look at SNOMED, that's the way our terminologies divide those causes in that hierarchy that we rely on in Odyssey. Those pre and post capillary causes assort themselves into the WHO maintained groups. That is probably the most commonly referred to etiologic reasons for pulmonary hypertension. And the one that we're interested in is pulmonary arterial hypertension, which can be either primary and idiopathic or secondary to connective tissue diseases, drugs, toxins, and infections. One of the issues that was identified in that literature review is that these don't assort nicely, believe it or not, into the same, WHO's international coding classification for diagnoses. And so as of ICD-9, we didn't really have great codes for pulmonary arterial hypertension. ICD-10, we have primary pulmonary arterial hypertension, but not necessarily one that grabs all PAH. And with secondary pulmonary causes, we're left to try to code for other diagnoses that might be present and accounting for that pulmonary hypertension. So that was one of the issues that the reviewers identified. Oops, I'm sorry. As you work up pulmonary arterial hypertension diagnostically, as you get more and more suspicious of group 1, that one that we're most interested in, the diagnostic procedure that's the gold standard is to do a right heart catheterization. As you can see, that's invasive, so that's not done in all cases of pulmonary hypertension. The pulmonary arterial hypertension is given by a set of invasive vascular measurements that rule out contributions from this left side of the heart being a little bit higher and try to rule in a process that suggests pulmonary vascular resistance is high. That seems really clean on paper, but in practice, there's actually a lot of variability that can go into those measurements when they're made on the table. Finally, with respect to therapy, I actually thought I'd just ask Dr. Wiederald to quickly summarize this in maybe 30 seconds, because I want to yield the floor to Eva to summarize her study as quickly as possible.
Sure. Thanks, Evan. Hi, Jason Weatherald here from Edmonton in Canada. So pulmonary arterial hypertension patients, we do have effective treatments for them based on 3 pathways. These patients have low levels of nitric oxide and prostacyclin and high levels of endothelin-1. So endothelin-1 is a vasoconstrictor, and there's this class of drugs that block its effect called endothelin receptor antagonists. The nitric oxide pathway can be targeted through a class of medications called phosphodiesterase inhibitors or cyclic soluble guanylate cyclase stimulators, or riociguat. And then prostacyclin derivatives are complicated medications that can be administered intravenously, subcutaneously, orally, or inhaled. And then there's another related drug that is a stimulator of their receptor. In a small subgroup of people, we actually use high doses of medications called calcium channel blockers, which are used for regular hypertension in the systemic circulation, but can be used effectively in about 5 to 10% of patients. Sometimes they're on blood thinners, although this is decreasingly used. There's never been randomized trials that have supported their use. But importantly, these drugs are only really approved for pulmonary arterial hypertension, but in the real world are used off-label for the other subgroups that are more common, but are not approved by regulatory bodies in those groups, with the exception of group 4, which is related to chronic thromboembolism. One drug, riociguat, is approved for use in that group of people. And importantly, in the true group 1 pulmonary arterial hypertension, most patients are now treated with 2 medications at the time of diagnosis and often end up on a 3rd medication at some point during their disease.
Great, thanks, Jason. So far, the work done to date, 40 manuscripts identified for review, 15 selected. From that, they removed prospective studies, registry studies. Additional papers were added from a review article. Data extraction was performed on 11 manuscripts. Some of the themes that I alluded to, so obviously loading on some of those ICD concepts, but again, we know they struggle to identify particular classes of pulmonary hypertension. And so within this space, we see a lot of reliance on algorithms that also require a treatment or require a diagnostic procedure like pulmonary arterial catheterization. And then both clinically and in these algorithms, there's a theme of looking to exclude other classes of pulmonary hypertension, here listed, CTEPH or group 4. But we will get into more details as we work through replication of these cohorts. And again, big thanks to the folks who did this work. I'll yield it here now to Eva-Maria to summarize some of the work they did in code-based algorithms in this space.
Okay, thanks. Yes, I'm Eva. I'm a member of the epidemiology team at Johnson & Johnson working on rare diseases. Next slide, please. Or shall I share my screen? I can also share my screen. Okay. I'm giving this presentation on behalf of my lovely study team. So on the one hand, we did some work some years ago using Phevaluator to validate PAH phenotypes, but then also we did a recent study in collaboration with Stanford University with Roam Samanian and his team to do a clinical validation in an EHR database that could be linked with a clinical PH database. Next slide. Okay, I think I will skip this because Evan, you already gave a nice introduction to PAH and the challenges to identify patients. Maybe some words about the first work, this is the Phevaluator work. At that time, we also did a literature search. So we only validated algorithms that we found in the literature. Then the more recent publication where we worked with Stanford University, there we also played around a little bit with our own algorithms. Especially we played around with temporal aspects of the algorithm, which was in literature, we often didn't find information on temporal sequences of, for example, procedure and diagnosis codes and time windows in between. Next slide, please. So yeah, let me focus on the clinical pH phenotype validation, as I guess most of you know Phevaluator and how it works. So here we were really in the very lucky situation that in Stanford there was an EHR database, or is an EHR database, that through unique patient identifiers can be linked with a clinical pH database. And the clinical pH database contains patient data based on right heart catheterization. And as Evan said, that's the gold standard for a definitive pH diagnosis. So based on right heart catheterization, we know if a pH patient has PAH or another type of pH. So yeah, we used the EHR database to apply the phenotype algorithms. We used the pH database to check if the patients were correctly grouped as PAH versus other types of pH. For this study, we used 6 published algorithms. We couldn't use all the algorithms because in the EHR database, for example, it was not possible to distinguish between in and out patient claims, which some of the algorithms contained as algorithm components. Yeah, and algorithm performance metrics were sensitivity, specificity, PPV, and NPV. Next slide, please. Yeah, we can continue with the patient funnel. Yeah, we focused on patient. One slide back, please. We focused on patients that were 18 years old or older. Of course, they had to have linkable records. They had to have a right heart catheterization, a confirmed diagnosis based on the right heart catheterization. What was interesting to see is that among the patients who had definitive PAH diagnosis, more than 1/4 of these patients actually also presented with a different type of pH. So not only PAH, but they presented with competing risk factors. So they were classified as PAH patients, but also different type of pH patients. So for sensitivity analysis, we looked into those patients alone that had only had a PAH diagnosis. Next slide, please. So these are the results. I don't want to go into detail, but I think what's very striking is that if we have a very sensitive algorithm, for example, an algorithm that just uses diagnosis codes, the specificity was super low, and vice versa. If we had a very specific algorithm, the sensitivity was usually very, very low, but we also had some algorithms that were quite balanced in terms of sensitivity and specificity. Next slide, please. Let's jump to the next one with the final conclusion. So there is no best algorithm, but what was very interesting to see is that in the case of PAH, exclusionary criteria turned a very sensitive algorithm immediately into a super specific algorithm. So once we used exclusionary criteria for other comorbidities, other types of PH, we ended up with very few patients. The balanced algorithms, they used very well-defined temporal sequences of procedure diagnosis and drug codes, but no exclusionary codes. And as I said in the sensitivity analysis, which I mentioned previously, if you only look into patients that have a very clear PAH diagnosis, no competing risk factors, the ranking of the algorithms was the same. And also when we looked into the characteristics of patients that got selected by the different phenotype algorithms, we actually only found random variations in these patients' characteristics. And actually, our findings are very much in line with expert recommendations and also very much in line with our previous work where we used the Phevaluator. Next slide. Yeah, so our recommendations are to tailor algorithm selection always to the specific research question. Next, please. Then to revisit the research question, assess all relevant patient characteristics, maybe you need to add additional criteria to an algorithm besides those that we already have in the validated algorithms. Next, please. Then it's important to include temporal components. Unfortunately, in the literature, we often didn't get information on temporal sequence and time windows in between. And there it's very important to also think about the healthcare system. So in some countries, it might be common practice to enter a diagnosis right after the procedure. In other countries, it can take up to a year until we find the definitive diagnosis in the databases. So that's very important to think about this as well. Next. And one more, please. Yeah, so overall, this was a very robust way of validating phenotypes. But of course, at the same time, the PH database comes for a specialized center. So PH prevalence in that database might be biased among PH patients. And we cannot say if the results are generalizable or to which extent they are generalizable. So we really suggest performing additional case validation studies of that kind in other databases and other healthcare settings, if possible, of course. Next slide. Yeah, so this is a comparison between the Phe-Evaluator work and the clinical validation. So the study designs were, of course, quite different. But I think since time is over, I will stop here. Maybe we can just show the last slide, and but I will stop at that point. I think what we were able to provide is really a range of universally accepted fit-for-purpose data phenotype algorithms, but still the user would have to tailor the choice to address the research question properly. There is no best algorithm, but we hope that with these two approaches, the Phe-Evaluator work and the clinical validation, we can inform future phenotype validation work, especially for rare and complex diseases where it's really difficult to identify patients accurately. Okay, thanks.
Great. Thank you, Eva.
Thank you,
and
Eva.
also thank you, Evan and Jason. I think what I would encourage the community. So I know we're focused on PAH, and I think it's a great opportunity to dive in. But I really encourage everybody to take a look at Eva's paper, because I think it actually just serves as a really nice role model of how to think about phenotype evaluation, no matter what disease you care about. And so it's a really nice demonstration of that. Azza, did you want to close out next steps for the Phenotype Phebruary?
Yeah, so in the last week, we're gonna go ahead with the PH, replicate the algorithm that we found, which is what also Eva mentioned in her, and they studied. So it would be, so we have this paper that evaluated those already, and we can replicate them as well. And then we're going forward with the major depression, and I put in the chat where we are. And then yeah, we will review cohort diagnostic for all the PAH cohort next Monday on a call that includes Eva and Jason and all the experts. So keep your eye on this and please join. It will be a very interesting, more depth discussion for PH. Jamie also had successes in running the study packages in Tufts, and he's going through with other data partners who signed up. And then our last activity will be the manuscript, which we will discuss also in a separate call next week. So everything will wrap up, and we'll see you next week to have our closure. Yeah.
And I'll just chime in quickly that we're hoping this serves as a prelude, in terms of defining phenotypes and their operating characteristics in our databases for future network studies in this area. And I didn't know, I just saw that Dr. Zamanian was here. I didn't know if there was any other comments him and Jason wanted to close on, just in terms of real world evidence needs in this space, or any comments around the study that you participated in, Dr. Zamanian.
Thank you, Evan. Just a real quick question. This is really a pleasure to be on this call. I think as a rare disease, the need for us to investigate associations or concerns that we have with PAH is real, but it's difficult for us to get to the large data sets enough. And, near and dear to my heart, as you and I have talked about, is the potential association between amphetamines and now prescription amphetamines and the development of pulmonary vascular disease. Eva and I have done a little bit of work on that, but I think I look forward to being part of this collaborative and maybe putting forward some potential ideas from the community to see how we can investigate that further. So that's the only comment. But I think this is a really exciting tool for us and collaborative for us as a rare disease group to be able to tap into.
Fantastic. Thanks a lot. Jason, anything from you?
No, I'd just say like a really well done work, Eva. I really like your paper, and I think this a lot more work needs to be done outside of the U.S. I think to validate these things because the use of these medications is actually less restricted in the U.S. And so these algorithms may perform better potentially in different health systems, and I think that work is just starting to be done right now. But this is really foundational to look at some of the other things associated with PH, like the complications of PH, like heart failure, transplantation. We can look at outcomes on a large scale if these algorithms work well. So congratulations.
Great. Well, thanks guys for joining and learning about all our work groups. And in the process, you really contributed a lot to all of this discussion. And really, thanks, Eva, for highlighting your work. It's really impressive work in this area.
Yeah, and really looking forward to this week being a chance to be a catalyst to get the whole community focused on seeing how well we can phenotype PAH and using that as a jumping off point to come up with network studies as Rome and Jason are highlighting for us, which would be really wonderful. Thank you all for joining. Thanks for our work group leads. Thanks for everything for Phenotype February. Look forward to seeing you all next week in March. But enjoy the rest of Phenotype February. Thank you, everybody. See you all next week.